of uh, National Postgraduate Medical College of Nigeria preparatory class. I'm Yahya Mohammed. I'm going to take on question number 6. The questions read thus. A 33-year-old newly diagnosed HIV lady with normal clinical examination findings. She has hepatitis B E antigen and hepatitis B surface antigen positive and a normal CD4 count of 525 with a high viral load of 125,000 copies per mil. Our HB is 8% with a deranged urea and creatinine. So the question that follows are, 1, what are the combination of HATs will you use and state the reasons for your choice? B, list 2 adverse drug reactions of the drugs listed above. C, list the 5 investigations you will do for this patient. D, what are the public health interventions you will carry out? E, if this patient develops ascites, what are the additional investigation you do? Okay, having looked at the questions, I try to highlight the key important things about the patient, about the question, sorry. So she's a 33-year-old lady. She's sexually active. She was newly diagnosed to have HIV. However, she has a normal clinical exams. Her HB-Sag and HB antigen are positive. She has a very high viral load, very, very high indeed, of 125 copies per mil, and a normal CD4 count of 525. She has deranged urea and creatinine. Likely she has some form of renal impairment. She has low hemoglobin levels. So these are the highlights from the question given to us. If we are to stage this patient, we are not given any symptoms, and most of the staging, they use CD4, like the CDC, and for WHO, which predominantly use clinical features. So not given symptoms for this patient, we can say in terms of HIV, likely she is in stage 1, and for CDC, she's stage 1A. So again, we are not giving other hepatitis B viral markers. However, this could go for acute viral hepatitis, though we are not giving hepatitis B co-antibody, whether it's predominantly IgM or IgG. So to answer the first questions, what are the combinations of HATs will you use and state your reasons? 1, we need to understand what are those drugs. If you look at the question, she's a young lady with HIV, hepatitis B, viral co-infection. So the combination that we use should be antiretroviral agents that have both hepatitis B and HIV activity. So these are the drugs listed above. In terms of their efficacy, tenofovir is known to have 3 pluses activity against HIV and also the same activity against hepatitis B virus. Likewise, its brother tenofovir alafenamide, it also has almost the same efficacy. Emtricitabine has 2 pluses activity against hepatitis B and also against HIV. Likewise, lamivudine, but they have some shortcomings in their use, which we'll mention later. Then entecavir is also having a very, very good hepatitis B activity, but very less activity against HIV. It has almost 3 pluses activity against hepatitis B, but only 1 plus activity against HIV. Telbibudin has just 2 pluses activity against hepatitis B, and its effect on HIV is debatable, with many thinking it doesn't have anything, any activity against HIV. So these are the combinations of drugs that we should look into for this kind of patient. So to answer this question, having this in our mind, there is a recommendation that said the recommended treatment of HIV, hepatitis B co-infection is a regimen containing TDF or TAF plus emtricitabine or TDF TAF plus lamivudine. So this should be at the back of our mind. This should form a backbone of any treatment of patient with hepatitis B, HIV, hepatitis B viral co-infection. So looking at that, however, our patient was given deranged urea and creatinine, which suggests some form of renal impairment. So we have to be cautious of tenofovir. That's one of the drawbacks of tenofovir, and that's why the need for formulation of tenofovir alafenamide, which has less renal toxicity and also less bone mineral activity. So looking at that, the suitable combination that will suit this young lady with hepatitis B virus and HIV co-infection, as outlined above. So it could be tenofovir, lamivudine, and efavirenz, or tenofovir, emtricitabine, and efavirenz, or tenofovir, alafenamide, lamivudine, nevirapine, or tenofovir, alafenamide, lamivudine, nevirapine. So these are the various combinations that we use. Most of the guidelines did not tell us which third agent should we add to this. But however, the backbone must be either tenofovir or tenofovir alafenamide, like in this case, patient that has renal impairment, with either lamivudine or emtricitabine. So I don't know whether we can use PPI in this case, but based on the knowledge I have for the guidelines, usually the first line starts with the backbone of nucleoside stroke nucleotide reverse transcriptase plus non-nucleoside reverse transcriptase. So this is these are some of the suitable combinations that will be suitable for this patient. The reason being that one, because they say we should state the reason. Tenofovir alafenamide has a very good efficacy against both HIV and hepatitis B, and also it is less renotoxic, and also has less bone mineral disease effects. However, it has shown to have some slight dyslipidemic effects compared to tenofovir, but overall, it's one of the most suitable for this patient. So any of the combination, it will be suitable for index patient. The next question is adverse drug reactions of the listed drugs. We listed like 3, 4, 5 drugs. So looking at their adverse drug reaction, tenofovir is a nucleotide reverse transcriptase, and we know nucleoside and nucleotide, they have a family effect, which is lactic acidosis. Majority of them have lactic acidosis. So apart from that, renal impairment and bone dysfunction. Tenofovir alafenamide also doesn't have more renal impairment and bone dysfunction, but also has lactic acidosis, and to some extent, some dyslipidemic effects, more than that of tenofovir. Lamivudine is also a nucleoside reverse transcriptase inhibitors, has that effect of lactic acidosis, which is like a group effect. In addition, it has some suggested it has some pancreatitis effect, but not as stavudine and didanosine. It also has some hypersensitivity reactions, but not as abacavir. Abacavir is notorious for that. Again, for some people that have HIV, hepatitis B co-infection, they use lamivudine monotherapy. They are known to develop hepatitis. And this is due to some mutants that is known to be associated with lamivudine. So these are some of the side effects for that. Emtricitabine, yes, is also a nucleoside reverse transcriptase inhibitor. It also causes lactic acidosis. However, some of the peculiar side effects for that are hyperpigmentation and also hepatotoxicity, especially in HIV co-infected patients that stop abruptly or use it as monotherapy. So for nevirapine, we mentioned nevirapine. Nevirapine is a non-nucleoside reverse transcriptase together with efavirenz, and they have a group effect of rash. They are known to cause rash, and to some extent hepatitis, especially at the acute use of the drug. So nevirapine, skin rash, hepatotoxicity, and efavirenz is notorious for CNS symptoms like drowsiness, trouble sleeping, unusual dreams, and rash. So these are some of the side effects of the listed drug. The C question say list 5 investigation you will do for this patient. This is a young lady with hepatitis B virus and HIV co-infection. They were only given hepatitis B E antigen and hepatitis B surface antigen. We like to do hepatitis B panel to properly grade our patient because we need to have hepatitis B co-antibody, whether it's predominantly IgM or IgG, that suggests whether it's an acute or a chronic. We also need to do a liver function test. This will help us to know the level of transaminases, especially the ALT, abdominal pelvic scan. Hepatitis B is a spectrum of a disease that starts with hepatitis, acute chronic cirrhosis, chronic liver disease, or even hepatocellular carcinoma. So doing abdominal pelvic scan may help us to detect the stage of this disease. It is at the level of hepatitis or has progressed to chronicity or even chronic liver disease, whether it's decompensated or not. So abdominal pelvic scan is very important for that. They would like to do food blocker. We are only giving hemoglobin levels. We need to do other things. We need to look at the WBC, whether there are evidence of infection, whether there are other things that we can deduce from that. And again, whenever a HIV patient has high risk of developing hepatitis B, similar to hepatitis C virus, because of their shared mode of transmissions. So you also need to screen this patient again about for hepatitis C. It has shown that there are a very good association of hepatitis B and hepatitis C in the setting of HIV patient. Then this is a sexually active lady that has two sexually transmitted disease. It is very good to check for other sexually transmitted infections like syphilis. So these are some of the investigation we like to do. Then the next question is, what are the public health interventions you will carry out? The public health intervention I will carry out one for the lady that is diagnosed with recent diagnosis of HIV, hepatitis B co-infection, her close relatives, as well as the community she belongs to. So I itemize them as one. I would like to educate and screen close relatives of both HIV. Okay, her close relatives should be, I would like to educate them and screen them about HIV for HIV and hepatitis B virus infections. For those that are negative for hepatitis B virus following my screening, I would like to vaccinate them according to Nigerian guideline. Again, she's active, sexually active lady. Probably if she's married or not, she may have some sexual partners. So if she has sexual partners, I would like to vaccinate them if they are negative for hepatitis B, as well as immunization, which is recommendation for active sexual partners of hepatitis B virus. So I would like to do both vaccination and immunization. Then again, for her sexual partners being in a husband, especially if they are serodiscordant couples or partners, I would like to advise them for the use of protective barriers like condom by her sexual partners or husband. And if possible, to some extent, I may consider giving pre-exposure prophylaxis for HIV for her sexual partners. Then I'll early commence her on the effective regimen for HIV, hepatitis B co-infection, like some of the combination I highlighted above. Then the community she belongs, I'll also need to re-emphasize on educating them, sensitizing them, screening them, and also, as well as educating them about preventive measures against these diseases. And again, I may like to educate the community against the avoidance of stigmatization against this disease. So the E question says, if this patient develops ascites, what additional investigation can you do? My index patient is a young lady with hepatitis B virus co-infection. If she develops ascites, it could be a pointer that she's progressing, the disease is progressing, it's being in a spectrum, hepatitis B is a spectrum. Will it be that she developed decompensated chronic liver disease, likely through cirrhosis? Or will it be that she has background renal impairment? Will it be a high one that wasn't giving her ascites? Or less and less likely, will it be that she developed hepatorenal syndrome? What I'm thinking is less likely is ab initio she has a background renal impairment before the diagnosis of hepatitis. So, and hepatorenal syndrome is a form of functional renal impairment seen in a patient with background liver disease, having ruled out other common cause of renal impairment. So that is less likely. So having this in our mind, I would like to do acetic fluid analysis, looking for microscopic culture and sensitivity, and most importantly, albumin, acetic fluid albumin, and compare with serum albumin. Because if she developed cirrhosis to chronic liver disease, likely acetic fluid, the gradient for serum acetic fluid albumin gradient will be high, more than 11 gram per DL. So that will give more to the diagnosis of likely she developed decompensated liver disease from cirrhosis. I also like to do cytology to look at the cells. So other investigation I would like to do upper GI endoscopy. It is known that patients with decompensated chronic liver disease, they may develop as varices as well as other complications of portal hypertension. So this will help me. And if there is any of the complications, I will intervene. So other investigation I would like to do are urinalysis, which may help in ascertaining renal impairment, especially in the setting of HIVAN. Again, Abdominal pelvic ultrasound, again, despite I did it in the other, may also help to delineate other causes and other complications. So other investigation, I may like to do a renal biopsy, even though I'm thinking she could have Hyvan that wasn't, which may show enlarged podocytes that are baculated. So these are some of the investigations I would like to do for this patient. So I have some few slides about HIV, very few, maybe in the next 5 minutes. So HIV was first recognized in the United States in 1981 by US Centers for Disease Control and Prevention. This is when they detect opportunistic infections in HIV, like pneumocystis carinii at that time, subsequently called pneumocystis jirovecii, in homosexuals. They found a group of homosexuals are coming down with pneumocystis carinii at that time. So they tend to question why. Again, some men develop Kaposi sarcoma and some other AIDS-defining illness. So they put is an alert by US CDC to start. Something must have, there could be a background thing related to that. So the studies continue until 1993, when HIV was isolated from a patient with lymphadenopathy. And by 1984, it was demonstrated clearly to be the causative agents of AIDS. HIV, we all know, belongs to Retroviridae family and subfamily of lentiviruses. Other viruses belong to Retroviridae, HTLV1 and 2. HIV1 is the most common cause of HIV in US and worldwide. 2 was identified in 1986 in West African patients and was originally confined to the region, even though it was said now to spread to other parts of Europe and America. However, HIV2 was less virulent than HIV2 is less virulent than HIV1. So on the basis of DNA sequencing, HIV1 is divided into 4 distinct strains, MNO and P. This is CDC classification of, just to remind us of HIV/AIDS. You can see category A, they are asymptomatic. Category B, they have some symptoms, but not usually AIDS-defining illness. Category C, they have to some extent AIDS-defining illness. So looking at our patients, she is asymptomatic with normal clinical exams, only that she has some abnormal, elevated viral load and some renal derangement. So we could group her into stage A1. So this is WHO staging, just to remind us. And our index patient, we can place her in stage 1. She's asymptomatic. So stage 2, we can see varieties of diseases that group as stage 2: recurrent respiratory tract infections, less than 10% weight loss, herpes zoster, recurrent oral ulceration, angular cheilitis, and others. So stage 3, more than 10% weight loss, more than a month's duration of unknown cause of chronic diarrhea, persistent fever of unknown cause, more than 1 month, oral hairy leukoplakia, persistent oral candidiasis, pulmonary tuberculosis, and others. So these are the 8 stage 4, which are called AIDS-defining illnesses. We can see them a lot: extrapulmonary TB, pneumocystis, and pneumonia, HIV-related Western syndrome, PML. So this just to brief remind us about classification of antiretrovirals. This is the most widely classified antiretrovirals, only that the nucleoside reverse transcriptase, they are grouped with nucleotide reverse transcriptase. And tenofovir is a very good example of nucleotide. All the other ones are nucleoside reverse transcriptase. We used to have a code in medical school called Z-square LATs: zidovudine, zalcitabine, lamivudine, abacavir, jadinosine, and stavudine. So non-nucleoside reverse transcriptase END, efavirenz, nevirapine, and delavidine. Then protease inhibitors, ritonavir, atazanavir. We have an acronym called NASIR, but when we finished medical school, they discovered atazanavir and lopinavir, so we added AL, al-NASIR. That covers for all of them. Nelfinavir, amprinavir, saquinavir, indinavir, ritonavir, and atazanavir and lopinavir. Entry inhibitors, enforvitide, CCR5 inhibitors, maravir, integrase inhibitors, reltegravir, and dolutegravir. So we should know the side effect. The group, they have, some of them have group side effects, especially the major ones that I use, like nucleoside stroke nucleotide. Most of them have lactic acidosis. And some few other ones, like zidovudine, may have lipodystrophy in addition to anemia. Ledanosin was notorious for pancreatitis, stavudine for peripheral neuropathy, lamivudine, as we mentioned, rash, and also for mutants and resistance and development of hepatitis. Abacavir has some yes, hypersensitivity too. Tenofovir, as we mentioned above, nevirapine rash, hepatitis, efavirenz CNS dysfunction, hepatitis, and rash. Proteins inhibitors, they are known for dyslipidemias and raised blood glucose, so they may have a metabolic effect. So these are some of the side effects. Apart from what I mentioned, most of them, they have some GI disturbances that warrant you a clinician educating patients. So this is head-to-head comparison of tenofovir alafenamide and tenofovir. You can see tenofovir alafenamide has less kidney damage, greater retention of bone mineral density, and similar viral suppression, but has some greater lipids. So these are some of the recommendations for treatment of about hepatitis B, HIV co-infection. I think these are some of the last slides, maybe 2, 3, 4 slides. Patients with HIV infection are greater risks of HIV, hepatitis B virus infection due to common route of transmission. Patients with HIV infection are at higher risk of developing cirrhosis, hepatic decompensation, and hepatocellular carcinoma, just like our index patient that we're thinking she developed decompensation. Treatment of HIV infection may improve virologic, histologic, and clinical evaluation of chronic hepatitis B infection. Hepatitis B virus infection does not appear to influence the natural history of HIV. However, in HIV co-infected patients, there is a significant reduced rate of clearance of hepatitis B antigen, and the risk of developing chronic infection is increased. So these are our index patient because she has background HIV. We shouldn't expect the clearance for HBe antigen might be reduced, and also she has a high rate of progressing to chronic infection. Hepatitis B virus infection reactivation and infection is also seen for, with co-infection with HIV. It is associated with threefold increase in development of persistent hepatitis B surface antigenemia, and there is 4 to 10-fold increase in liver-related mortality. So this patient should be managed adequately and monitored. Treatment of hepatitis B virus infection alone without addressing the HIV infection will lead to emergence of HIV strains that are resistant to nucleosides. So it's not advisable that before there were criteria for treating hepatitis B. I used to remember then, before it was changed, that okay, any patient with CD4 count of more than 500 may not require treatment. Sorry, for the HIV. Anyone with 350 to less than 500 with symptoms of pregnancy warrant treatment. Anyone with less than 350 CD4 count will warrant treatment, irrespective of whether it's symptomatic or not. But I remember one of our teachers was telling us this is just to minimize the use of the drugs, because drugs are free, are given by some agencies. But I used to remember now that almost everybody with the disease should be treated, test and treat. So TDF is considered first line in treatment of chronic hepatitis B virus infection because of its high biologic efficacy and low risk of. So that is why TDF is considered among all the listed above drugs. TAF is associated with less renal toxicity and less effect on bone, and that's why it's suited for our patient. It's the best drug to give our patient. In treatment of HIV hepatitis B co-infection, a regimen containing TDF plus emtricitabine or TDF plus lamivudine should be used as a backbone, just as what we said and highlighted. Emtricitabine and lamivudine show efficacy against hepatitis B virus infection in both HBe antigen positive and negative patients. However, these medications are associated with greater development of resistance. So especially if used alone for monotherapy. These are some of my references. Thank you. We entertain more clarification comment from our teachers, from the ID physicians and gastroenterologists. Thank you all. Hello?
We can hear you. Well done, Dr. Yahaya. Dr. Dahatu's hand is up. We can hear him then. Once we're done with those that hands are up, we can read the comment.
Okay, man. Thank you. Should I stop sharing the screen because I can't see the? Well,
yes,
hold on.
You can stop sharing so you can
Because
see.
I may need to highlight somebody. Maybe somebody may point something to something I want to highlight.
Okay, let me see somebody that will assist you. Okay, who can assist? Somebody to volunteer to assist him while he's presenting. Dr. Dahatu, you can go ahead.
Okay, thank you, Ma, for the opportunity. Thank you very much, Dr. Haya, for the wonderful presentation. It's a nice presentation, actually. The choice of the regimen, you tried very much for the choice of the medication. However, most of the drugs you mentioned are actually obsolete in HIV care. We know one of the disease entity that has a rapid change in guideline, it's actually HIV. Sometimes over 3-5 years, you see a entirely new things in the system. The nevirapine has been phased out from the treatment of HIV in Nigeria and worldwide. And efavirenz also is not that very common. And looking at the lady, she is a young lady and is one that usually tend to have effect with nevirapine. So we usually shun away from nevirapine if somebody is a young lady. So we don't like to give them, especially somebody with hepatic illness, because it causes hepatic toxicity and other toxicity. So usually the treatment regimen, they shun away from nevirapine if patient is having co-infection. So, and efavirenz also has been phased out from the treatment guideline now. Most of the guidelines, they don't recommend efavirenz. So the backbone that should have been in the treatment for this patient is actually tenofovir, like you highlighted. But the question is so specific and is actually trying to draw our attention about the side effect of tenofovir. So the side effect mainly is renal toxicity. And although they did not give us the creatinine level, so usually once the creatinine clearance is less than 50, we don't want to give anything that contain tenofovir molecule, because TAF, that's tenofovir alapinamide, should have been also a replacement for it. But in most cases, for the ID physicians and the recommendation, once there is significant renal impairment, especially that they bring it out so prominent in this patient, so you shun away from tenofovir, you go for a regimen that doesn't contain tenofovir. So the next one that we should fall back on it, that is actually abacavir. Abacavir, and we can combine abacavir with lamivudine. And then the abacavir and lamivudine is a bit of a good compromise for the patient when you looked at the HIV care. But for the hepatitis B treatment, it's not a good regimen because there is very low barrier to resistance about the lamivudine component of the regimen. So it may not be the good one for the patient. So what the guideline usually recommend when you are faced with this kind of situation, you combine abacavir and lamivudine, and you have a fixed drug combination that contain lamivudine and abacavir. So then you augment it with entecavir, which doesn't have side effect on it. So, but the backbone will be abacavir, lamivudine. Then the other regimen that we are using, dolutegravir in Nigeria and worldwide, integrase inhibitors are now the first line recommendation for the regimen. So, meaning we give a patient this combination, one tablet that contains abacavir and lamivudine, and then a loose drug that contains dolutegravir for his HIV care. But lamivudine is not enough for the treatment of hepatitis B. Then we supplement or we augment with entecavir component so that we treat the patient for hepatitis B very well. And the other thing also, why they first out nevirapine and efavirenz in the treatment of HIV is also because of low barrier to resistance, meaning HIV virus easily develop resistance against the non-nucleoside reverse transcriptase inhibitor. So you see that most of the guidelines, they don't recommend NNRTIs. Then for the other things, I think you try very well for the answers, and they are very good. Thank you very much for the updates.
Thank you, sir.
Dr. Lawrence Ade, you can unmute and speak.
Okay. Thank you. Good morning, everybody. Good morning, Dr. Yaya, for the presentation. I just have one comment and a question. My question is about public health intervention for this patient. Your first point there is that you are going to screen the relatives of the patient for both hepatitis B and HIV. How will you go about that? Will you just go to their house to go and screen them? I want you to expatiate on that. So my comment is about the further, if a patient develop ascites, other investigation that you can do. I think in addition to the ones you have mentioned, to do acetic fluid gene expert is not out of place also, because he has a risk of having abdominal TB also. In addition to those ones you have mentioned, you can equally do acetic fluid gene expert, though the yield is low, but you can still do it if you can get something from there. Thank you, Dr. Yaya, for the presentation.
Thank you, Chief Ade, and thank you very much. Regarding screening of the relatives for both HIV and hepatitis, the question said the public health. I think I need to educate them first about the disease. Then, for those that are consented to screen, especially those that have not recently screened themselves, I'll offer them screening for both. Thank you.
Okay, thank you so much. Dr. Alhatu, you want to say something?
Thank you. Sorry for coming back. With regard to the public health intervention for this patient, we know the disease is highly stigmatized, so we have to be careful with mentioning we want to screen the family and relation, because at the end of the day, you may be exposing the patient's privacy to the relation, because the relation will ask you, why would you want to do HIV testing? And invariably, you are just actually telling them this person is having HIV. So I think the best it would have been a contact trace with the permission of the patient, and it's the patient that will bring out the patient to the managing physician. And then it's better to look at it in the public health aspect. You can classify them into primary, secondary, and tertiary intervention for the patient. At the community level and the relations is the primary prevention, health education, mass screening, awareness, and for the patient, the secondary prevention, early commencement of treatment, monitoring of the treatment, and then the tertiary, you manage the complications like the patient is already having. Thank you.
Thank you very much. I thought of that actually. I thought of that actually. Thank you.
So well done. Thank you very much for the comments and questions. Dr. Yaya, from the chat box, I think there are some questions. Let me quickly read them. Dr. Jafar is saying, thank you so much. You won't add abacavir-based regimen? That's a question. Then Dr. Andrew Godia is saying, thank you so much for the presentation. Why won't you use a dolutegravir-based regimen? I think Dr. Alhato has gave a detailed explanation on the proper regimen. Then Dr. Linda is saying, thank you for your presentation. The dolutegravir-based regimen has been found to be better for HIV. Combinations with abacavir are made if there is renal impairment. Patients are then placed on a separate antiviral medication for hepatitis B virus. Kindly explain why you made your choice. Thank you. Dr. Jaffer is saying, is there any fare for IRIS, in index patient? If yes, what type? Another question from Dr. Jafaru. He's still asking, how did you treat this patient? As chronic hepatitis B or acute? No hepatitis B viral load, no hepatitis B viral panel, bear in mind hepatitis B virus levels greater than 2,000 international units per mil, you treat. How about the dolutegravir-based regimen? That's from Dr. Oregon. Dr. Ifoma is saying, is staff available in Nigeria? Dr. Jaffer is still saying a sick fluid gene expert has been very, very poor yield. Adenosine might be more helpful, although not specific. Histopathological evaluation with positive AFB staining remains the gold standard for diagnosing abdominal TB. So, Dr. I don't know if you have some response for that.
Okay, I think some of the responses I have. Well, actually, I looked for the national guidelines to see what changes has been made. But most of the guidelines I saw, they said they did not tell us the third agent to use. They said we have to use the backbone of tenofovir, lamivudine, or tenofovir M3-cytarabine. However, for patients with renal impairment, like our index patients, we know tenofovir is notorious for renal impairment, so we have to go for tenofovir alafenamide. Actually, none of the guidelines has specifically said the third agent you should add, whether integrase inhibitors, whether but I wanted to dig further actually to look for more recent guidelines.
Sorry.
Yeah.
Sorry, presenter. What year were these guidelines?
Sir?
What year were the guidelines?
The one I use, sir?
Yes.
Sir, is I saw in Harrison's 19 edition. I think that was
You're reading it
2014.
in a textbook, but I thought you were checking national guidelines.
Yeah, I looked for it, sir. I couldn't. I
They are
call
not
a friend.
readily available. If you want to
Yes.
get those type of guidelines, you
Yes,
have to
sir.
look for centers that perhaps have a NACA unit within them,
Yes, sir.
or a center that has an infectious disease unit that may have access to those particular guidelines. So they're not things that you readily see online. They're
Yes,
things
sir.
that you may have to ask somebody in that specialty. Or even if you ask the people in dermatology, venerology, they may have access to it, because there is a lot of shifting, a lot of changing happening in the landscape of HIV, TB, you know, a lot of things are changing. Okay, so it's important that we, try and keep our breath by asking those people that perhaps see those patients more than we do,
Yes, sir.
to give us some insight. Yes.
Okay.
That's just
Thank
what I
you.
wanted to add.
Thank you, sir.
All right. Yeah, because some of the things you're saying are quite, I wouldn't say outdated, but they're not up to date.
Yes, sir.
Yeah.
Thank you.
Thank you so much, sir, for that comment. Dr. Dalhatwa is an ID physician. He has given, I think, an updated information. Dr. From the chat box, there's a question on, do you have any fear for iris and what type? I think that has not been addressed.
I think the fear of iris could be there, immune reconstitution syndrome, that a patient with a very low immunity, starting those active agents may trigger further worsening of immunity. But when I'm approaching this current guide treatment for hepatitis B viral co-infection, I've not seen any warning regarding to that. But it actually do exist in certain active drugs for patients with very low immunity, very low CD4 count.
Okay, thank you so much, Dr. Jaffer. I don't know if you have a comment regarding that. You can send us in the chat box, please. I don't know, any comment from the facilitators? It's almost 7:40. Kindly unshare your slides, Dr. Aya, so that we have the next presentation.
Okay, thank you.
I think who is the next presenter?
I'm the one. Dr. Yahya is helping me share my
I'm
slide.
fine.
Okay, excellent, excellent.
Okay, I should share your slides.
Yes, please.
Okay. Okay, go ahead.
No, it's question 5, not question 3. Let me send it to you. Okay, good morning, House. I'll be taking question number 5, November 2022. So the question, a young man with cough, in brackets, blood-stained, wheezing, no weight loss with widespread bronchial breath sounds, and eosinophilia of 25%. First question goes, what questions will you ask him? B, list 5 differentials. C, list 5 investigations to carry out in order of priority. D, results shown, ascaris 3 pluses, others negative. What is your diagnosis? E, how will you treat the patient? So please, next slide. So the first thing I'll ask the patients in the biodata, the most important thing will be to know the patient's occupation. Specifically speaking, I would like to know if the patient is a farmer or the patient does any form of riverine work, maybe even fish farming. Then I would like to know the history of the presenting complaint. They already told me that the patient had cough, but I want to know whether this is an acute onset, whether the cough is of an acute nature, or whether it's also of a chronic nature. I want to also know, aside the blood-stained aspect of the cough, I want to know whether it's associated with other things like maybe pain on breathing in, pleuritic chest pain. And then for the blood-stained aspect, I would want to confirm if the patient actually experienced hemoptysis, or maybe the patient is even having hematemesis and calling it hemoptysis. So I'll ask for GIT features to rule out GI symptoms like nausea, vomiting, or even other questions that would rule out disease like peptic ulcer disease or liver disease. Then for the sputum, I want to know if it contains blood in clots, whether the blood is appearing as coffee grounds or whether it's just bright red. Associated features of fever, maybe ear discharge, upper respiratory tract features, catarrh, to rule out upper respiratory tract infections. Then I also want to rule out the features that link to COPD, bronchiectasis, maybe whether the sputum gets worse or maybe changing position. And other causes of hemoptysis like pulmonary embolism, by asking questions like calf pain or even pain on breathing in. They've already told me the patient does not have weight loss, so it's unlikely to be a neoplastic process, but I'll still rule out bone pain or even the presence of swellings in the neck or lymphadenopathy. Now, an important history I want to get from the patient is whether he's maybe traveled to a riverine area or an endemic area of tropical disease, like maybe the village. also want to know the use of medications like anticoagulants or generally any medications that the patient may be on, because some of them can actually cause cough and blood-stained cough as side effects. Then I want to rule out cardiogenic causes of hemoptysis as well by asking questions that rule out shortness of breath on exertion, leg swelling, and then also if the sputum is frothy pink, which is characteristic of cardiogenic hemoptysis. I think that's all I'll ask for now. And then the next part of the question says
list 5 differentials.
Yeah, list 5 differentials. So going from the information they've given me only, my first differential would be an eosinophilic pneumonia, and that's because of the 25% eosinophilia that was noted. My second differential would be bronchial asthma complicated by respiratory tract infection. The third one would be Church vasculitis. The fourth one would be paragonomiasis, and the fifth one would be hypersensitivity pneumonitis. Please, the next slide.
So 5 investigations.
So the 5 investigations I'll do for the patient, the first one will be a chest X-ray. Chest X-ray will help me because if it's bronchial asthma that's been complicated by respiratory tract infection, and I see areas of opacity or areas of consolidation that maybe suggest pneumonia. And also, I may also see other complications of bronchial asthma, maybe like hyperinflation of the lungs. The next one will be a sputum MCS. A sputum MCS should be necessary to rule out any form of bacterial infection. Then stool microscopy will be helpful because of the eosinophilia. I'll be thinking of a parasitic infestation. So stool microscopy for ova of roundworm. Then I will do a chest CT. Chest CT as an additional imaging to maybe to see to identify maybe shadows in the pleura. Sorry, shadows in the lung field. Serum IgE may be raised, especially in patients that have eosinophilic pneumonia, and a full blood count will show eosinophilia, or if it's a bacterial infection, it will show elevated white cell count and neutrophilia. So my most definitive diagnosis, the next slide, is Loefflers syndrome, also known as acute pulmonary pneumonia. It's a type of eosinophilic pneumonia that is seen in association with certain medications, but most commonly with parasitic infections like Aspergillus lymphocoides, Strongylitis decoralis, Nectar americanus, duodenalis. So what happens is that when these worms enter the body, either through oral ingestion or through penetration of the skin, they migrate through the lymph nodes, get into the pulmonary bed, and then when they're in the pulmonary bed, they can cause a form of transient pneumonia, which is associated with eosinophilia. Patients that have this form of pneumonia may not even have any symptoms, or they may just have mild symptoms like cough. Maybe there may be blood stain, just like in this indexed patient. Drugs that are known to cause this, NSAIDs like aspirin, even diclofenac, antibiotics like penicillin, anticonvulsants like phenytoin are also known to be associated with Loefflers syndrome. And on imaging, patients just have transient shadows in the hilar area, and they also have elevated blood eosinophils. So the treatment for Loefflers pneumonia is usually self-limiting. So you watch and wait. As most patients that have it, it usually resolves spontaneously. But if you get a positive stool microscopy for ova of roundworm, you have to treat the patient with an antihelmintic medication. So albendazole will be given. Also, in severe cases where the patient has extensive or very productive cough, that is severe, steroid may be used to reduce the hypersensitivity reaction up to the doses of 60 milligrams orally of prednisolone, and then gradually tapered down. I think that is the last question.
Okay, well done, Dr. Sylvia. Sorry, I'm sharing the screen. I can't see the background. Maybe somebody should.
Okay, Dr. Yahaya, well done. Dr. Dahatu is on. Dr. Yem is Dr. Thank you. Dr. Dahatu's hand is up. So you can go ahead, please.
Okay. Thank you very much for the presentation. Thank you, Ma, for the opportunity. Sorry, it's like I'm disturbing the class.
No.
The differential diagnosis. Sorry, Dr. Ha, can you scroll down to the differentials she outlined? Like they used to tell us, most of these questions, it's not that you're going to see all of them at the same time. So they will be asking is a question will be in chains. So the differential diagnosis, they say common things occurs commonly. I think tuberculosis was omitted in this differential diagnosis. We know one of the important illness, respiratory illness that comes with hemoptysis in our environment. Tuberculosis is one of them. The pneumonia also is one of them. You can see that in your investigation. You were investigating for pneumonia, but in your differential diagnosis, there's no differentials of pneumonia. So I think the pneumonia should be part of this differential diagnosis. Pulmonary tuberculosis also should be part of this diagnosis, especially, but I'm happy with the paragonioniasis is as part of the investigation. And then we should remember that we should be careful with steroid in patients with infections, especially patients with helminth infection. They can cause hyperinfection, and it can even cause intestinal obstruction. And then the explanation for hemoptysis that patients with helminths, they tend to have, we know it's either we are ingesting the eggs or the ova of the parasite, or they are penetrating, the larvae are penetrating through the skin. Whatever happens, they get into the bloodstream. As they are ascending upward, they are having mitotic development, meaning they are growing in size, and they are going through the capillaries. What they explain in the pathogenesis is as they get towards the pulmonary capillaries, their size is bigger than the blood vessels, and therefore they cannot continue to move through the cardiovascular system. So they have to break down the pulmonary epithelium, and that's why we tend to cough out the organism at that range, because their size outgrow the diameter of the blood vessels. And that's why in the process, an individual could have a blood streak in their sputum they produce. It's usually a self-limiting that you mentioned. Thank you very much. This is a good presentation.
Thank you, Dr. Dahatu. And please, thank you so much for your contribution. We appreciate it. Please. It's not a disturbance, it's a discussion, and I'm glad you're sharing your knowledge. So thank you so much. Thank you.
Okay, thank you, sir.
Dr. Kayode. Dr. Kayode's hand is up. Please, you can go ahead.
Good morning, everyone. Just
good morning.
One major comment. Though I was a bit distracted here because of presentation, but at least I got quite a lot. Thank you for the presentations, were lovely and straight to the point. But my area of emphasis from the questions, they put 25% eosinophilia, if I can still vividly remember. And that is actually a point or an area not to overlook. So that means the emphasis should be more of hypereosinophilia or philic syndrome than any others. So your differentials should contain those that actually causes hypereosinophilia.
I can't hear him again. I can't hear him.
Sorry, Kemi. The broker.
I can't hear him.
Hello, sorry, you call Kemi. I have to put it.
Oh, okay.
The broker asthma you mentioned, I don't think it has to come early. It was
It's breaking
too
again.
early because sorry, a call is coming in. So in summary, we should focus more on hypereosinophilic differentials. Just like you mentioned some of them, like drug, NSAID, nitrofurantoin, infective causes, which you mentioned, Loefflers syndrome, bronchiolitis, even malignancies, which could be hematologic.
I can't hear what he's saying now. I think it's network.
Like rheumatoid, Sjogren's, sarcoidosis, even the Wegener, that's eosinophilic granulomatous polyangiitis, the other hyper. So the summary here is that we should focus. The summary, sorry, you kept on calling. Someone kept on calling me. The summary here is that we should, as much as possible, tailor our differential and our answer towards the questions. And that is just the point of emphasis. Thank you, the presenter and every other person in the house.
Thank you, sir.
Thank you, Dr. Kayode. Thank you so much. It's nice to hear your voice after some time. Well, I've missed you in class. Dr. AEC, thank you.
Thank you, Dr. Christabel.
There are no more comments. I don't know. There are no more hands. I think it's let me see if there are any comments in the chat box. Okay. Dr. Mahmoud Jafar, please, this is your long list of contributions. Since you know how our meetings can be, it's best you put it in the WhatsApp so that everyone will have access to it. Thank you so much. Okay, yes, I think that one is your duration. Okay, yes. So from Dr. Mahmoud Jafar, what question to ask? Does he rear or encounter with big dogs, hand-to-mouth ingestion of agriculture product or food in such cases? Any history of drenching, night sweat, anorexia, rash? Does he live around water bodies, eat crustaceans, consume raw meat, wild boar? And when last he took such, does he stay around poor sanitary areas or inadequate sewage disposal? Is he a known asthmatic? Family history of atopy, history of cancer, any history, Dr. Jaffa, any previous diagnosis of cause or COVID? Any history of trauma, foreign body, ENT procedure, history of immunosuppression, DM, cancer, or chemotherapy, HIV. So differentials are endemic hemoptysis, pulmonary ascariasis, tuberculosis, pulmonary TB, atypical pneumonia, pulmonary filariasis, bronchogenic carcinoma. Investigations, chest X-rays, sputum for genus part, and the MCS. Lubricants and differentials, peripheral blood film, serological assay, axillary lubricants, glycated hemoglobin, RVS, diagnosis is Loefflers syndrome from pulmonary ascariasis. Treat with albendazole, 400 milligram daily for no duration. So then from Dr. Nduka Ijoma, Dr. Yaya, please, is this patient qualified to be classified as WHO stage 1, that is asymptomatic with this? Dr. Nduka, who are you asking this question? Dr. Yahaya is not the presenter. Then from Dr. Chibike, past medical history for this patient should also explore histories that may point to acute rheumatic fever, rheumatic heart disease, in his suspicions or in the suspicion of mitral stenosis, ascariasis was also +2 also and should be taken into consideration. Occupational history for IELTS. So thank you everyone. We appreciate your comments, your contribution. Dr. Mahmoud, please, that long list you gave, please put it on the WhatsApp so that everyone will benefit from such and detailed contribution. Thank you so much. Dr.
It's already been posted.
In the WhatsApp group, that's nice. Well
Yes,
done so
Dr.
far.
Mahmoud's essay has been posted.
Thank you. Thank you. Dr. Yemis, Dr. Yisi, thank you. I know I keep calling Yemisi. Dr. Yisi, thank you so much. The first presenter, Dr. Yahaya, thank you. We appreciate you all. Don't know if any facilitators have any comments before we close the class. Dr. Prof is around, Dr. Pununga is around, Dr. Cookie is around. So any comment on the presentation? So before we go over to other things, let me put off what I should put off. Let me put it off just to be sure. Just to be